Hello. Endoscopic retrograde cholangiopancreatography is a procedure which all endoscopists wish to master and perform. The procedure, although it looks simple in the hands of experts, can be challenging for the novice because of the intricacies involved in this procedure. Cannulation of the common bile duct through the ampulla of Vater is the primary step that is required in order to perform an ERCP and further therapeutics in the bile duct. Today we are going to discuss the various methods that are used for cannulation of the bile duct. Step by step, each procedure will be discussed in detail. Cannulation of the bile duct can be achieved by a variety of instruments and a combination of many techniques and methods. The various instruments used to cannulate the bile duct are cannulae, sphincterotomes, either independently or along with a guide wire, or sometimes a pre-cut papillotomy, or which is also called as an excisotomy, may be required in order to perform ERCP and bile duct cannulation. In this video, we are going to describe and demonstrate three different methods of cannulation. The first method will be cannulation along with using a sphincterotome and a guide wire. Wire guided cannulation is the commonest technique employed to perform bile duct cannulation. A sphincterotome or a cannula is preloaded with a guide wire. The guide wire should typically have a floppy tip. The Dream wire from Boston Scientific is a very convenient wire to use for bile duct cannulation. This is because the tip of the wire is very floppy and can really find its way into the bile duct. This is because the tip of this guide wire has a special hydrophilic coating which finds its way very easily into the biliary tree. I prefer to use a sphincterotome rather than a cannula for performing bile duct cannulation. There are various reasons to choose or to prefer a sphincterotome over a cannula. The primary preference is because a sphincterotome can be bored using the cutting wire in order to change the axis of the cannula and the guide wire during cannulation, which cannot be performed using a cannula itself. This can sometimes make cannulation using only a cannula and guide wire difficult, but it can be very easily achieved using a sphincterotome. The second advantage of using a sphincterotome is that once we have cannulated the bile duct and have obtained a cholangiogram, very often we will need to perform a biliary sphincterotomy in order to perform further therapeutics. In order to perform the biliary sphincterotomy, we need the sphincterotome in place, and if we have used it for cannulation, we do not need to exchange the cannula for a sphincterotome, which saves one step of the procedure. When we are talking about the wire guided cannulation technique, there are two variations that need to be discussed. The first variation is when the orifice of the papilla is cannulated using the sphincterotome, which is preloaded with a guide wire. In the second variation, which is specially used when the ampullary orifice is very small, the tip of the guide wire is protruded out of the tip of the sphincterotome for about 2 or 3 millimeters, and then this is used as a guide to cannulate the tiny ampullary opening, and it is followed in with the sphincterotome, which assists cannulation. We have an 86-year-old lady who presented with a history of severe abdominal pain and backache and vomiting yesterday, and her investigations showed that she has gallstone pancreatitis. Liver function tests and an ultrasound show that there is a bile duct, there is a small stone in the common bile duct and multiple stones in the gallbladder. liver function tests show a mildly raised bilirubin and serum alkaline phosphatase. We are going to perform an emergency ERCP on this lady to relieve the cholangitis because her WBC count is 16,000 and she has also had a spike of fever today. So we believe that there is an offending stone which is obstructing probably at the ampulla or in the bile duct and causing cholangitis. So you can see over here that the ampulla is not very well seen in the second part of the duodenum. It is possibly under this fold which is in the center of the screen, because you can see some dark and purulent infected bile draining from just below that fold. So I am going to use the Ultradome XL from Boston Scientific for cannulation. I prefer to use a sphinctertome rather than a cannula because it can help me to assist cannulation because of bending the wire, and it can help to change the direction, and also because I can perform the sphincterotomy without having to change the instrument later on. The sphinctertome is preloaded with a guide wire with a floppy tip so that I can find my way through into the bile duct without traumatizing the ampulla or the pancreatic duct. Now, in this patient, since she has gallstone pancreatitis, we have to be extra careful not to go into the pancreatic duct because that can aggravate the current attack of pancreatitis. Okay, so now we've started seeing a little bit of the papilla. You can see that pink mucosa. It is important to get your sphinctertome aligned to the papilla so that it passes from the 4 o'clock towards the 11 o'clock direction so that it can enter the bile duct. Now I am going to advance my sphinctertome. Now I use specifically three movements to get my endoscope aligned and the sphinctertome aligned to the papilla. It is a combination of the elevator, the up and down wheel, and also the right and left wheel. In addition to these three wheels movements, what we also do is some amount of torque right towards the right or towards the left, and also pushing the scope in or pulling it back. So it's a combination of all these five movements that helps us to align the sphinctertome to the papilla. It is important to see the entire papilla, especially the bulging portion of the papilla, which is the intramural bile duct, and it is this portion of the ampulla that we need to enter from this orifice down here. I am performing this procedure in a supine position because this patient has had a back surgery which prevents her from sleeping or lying down on her side or in a prone position. We engage the sphinctertome into the orifice of the papilla. Now you can see over here that as I engage, the tip of the sphinctertome is hitting towards the wall of the papilla. So what I do is I change the direction of my left wheel, make it slightly left so that I can align myself. And simultaneously my assistant bows the sphinctertome, bend the sphinctertome. As the sphinctertome is bowed, I advance the sphinctertome slightly into the papilla, and then using the elevator and the up wheel, we enter the bile duct. You can see over here that the guide wire has entered the bile duct, and you can see that the wire is parallel to the spine and not crossing the spine, which shows that it is into the bile duct. So now I advance my sphinctertome over the guide wire into the bile duct. At the level of the porta hepatis, we will keep the tip of the sphinctertome and then inject contrast to get a cholangiogram. A papilla situated inside a duodenal diverticulum is a specific challenge for the endoscopist. Cannulation of such an ampulla can often be very tricky because the ampulla is very floppy. The second reason being that the ampulla is situated at some distance from the endoscope, because of which maneuvering the instruments and the accessories becomes difficult, and often the alignment of the ampulla and the intramural bile duct is different because of the presence of the diverticulum. In order to achieve cannulation for an intradiverticular papilla, it is important to use a slightly straighter instrument. Here you will see that we have used a sphincterotome, but without much bowing of the sphincterotome, which assists cannulation of the ampulla and getting the guide wire into the bile duct. Okay, as you can see over here, the ampulla is situated in a very large periampullary diverticulum. In order to cannulate the ampulla in a diverticulum, very often you will need a slightly straighter instrument. So, we are going to use the Ultratome XL. You see this over here. I usually would start cannulation with a sphincterotome because it can give me the advantage of bending the wire and changing the angulation of the sphincterotome to aid cannulation, and then I can carry on with the sphincterotomy with the same instrument. However, I am going to use this sphincterotome without bending the guide wire, without bending the wire, so that I can keep it as straight as possible, because cannulation in a diverticulum very often is easier with a straight instrument. So, let us see. It is important to maintain the endoscope in the short loop position. Now, you can see over here that the ampullary orifice is very small. So, can I have a little bit of the wire tip? So, what I would do is bring out a little bit of the guide wire, which helps me to engage the guide wire and follow it up with the sphincterotome. And as I do so, I correct the position of my sphincterotome by rotating the small wheel either to the right or to the left. You can see over here that since the ampulla is slightly deeply situated inside the diverticulum, as I advance the sphincterotome has a tendency to go towards the 2 o'clock direction. Now, I need to correct this to come to the 11 o'clock direction. This I do by rotating the small wheel to the right, and now I will try and cannulate again. Okay. My assistant, she has bowed the sphincterotome slightly. Okay. So, now we will try and check if the guide wire can go in. I do not recommend injecting contrast at this juncture. Okay. So, the guide wire is going up slightly straight, but then it is coming back. So, let us see. You can see the movement of the guide wire, and there. Now, how do I know that my guide wire is in the bile duct and not in the pancreatic duct? You can see the spine over here. In this position where the guide wire is parallel to the spine or is not crossing or moving towards the spine, in the lateral position, this will often signify that the wire is in the bile duct. The second thing that we need to identify is that when the guide wire is in the bile duct, it will cross the endoscope, whereas if it is in the pancreatic duct, it will never cross the endoscope. So, now I follow it up with the Ultratome XL and I achieve deep cannulation. Today we are going to show you a pre-cut being performed using a needle knife sphincterotome. Keeping the ampulla in the center of the screen, the tip of the needle is engaged in the orifice of the ampulla and a stepwise layer by layer deroofing of the ampulla is performed. The direction of incision should be at around 11 o'clock or 12 o'clock direction. It should not be too much to the right nor to the left and should remain as close to the center as possible, because it is in this portion of the bulging portion of the ampulla that the intramural bile duct lies, and this is what we aim to find. Once a step by step, layer by layer deroofing has been performed, gentle probing of the incised portion can be performed using the sphincterotome tip itself. There are two indicators that we have opened up the bile duct. One is the orifice of the bile duct is usually seen as a salmon pink epithelium, which will be seen clearly against the white muscle fibers of the ampullary muscle, and sometimes you may see a few drops of bile coming out of this bile duct, which will aid in cannulation. Using both these indicators, we can probe and we can get into the bile duct. The probing can be done either with the tip of the cannula or sphincterotome or with a guide wire. It is important to remember that the probing should be always very gentle, otherwise dissection of the tissues can occur with edema and bleeding and result in pancreatitis. Hello, this is a 52-year-old lady presenting with pain in abdomen and raised liver enzymes, and ultrasound and CT scan shows a large stone in the common bile duct, about 2 by 1.7 centimeters. There are also multiple stones in the gallbladder. The plan is for this patient that we perform an ERCP and removal of the stone. We may possibly require mechanical lithotripsy, or we could try performing a balloon assisted stone extraction. So let us see what we find in this patient. So we are in the second part of duodenum and we are facing the ampulla. You can see the ampulla over here as a slightly bulging structure with fronds, and to identify the bile duct orifice, you can see that at the tip of the fronds a tiny punctum with some pink epithelium. Now that is usually the orifice of the bile duct. We are using an ultratome XL, a short nosed ultratome XL for cannulation. Now you can see over here that the ultratome is exiting at around 4 o'clock, and we need to go in the direction of the bile duct, which is about 11 o'clock over here, like this. Now, in order to orient the sphincterotome in the direction of the bile duct, what I do is I push the scope down a little bit, bring the up wheel closer to the ampulla, and torque the scope slightly in the clockwise direction, a little bit of left with my small wheel. I lock the wheel, okay, and now I advance the sphincterotome further. As you can notice over here, my sphincterotome is going to the side of this polypoidal structure over here, which is the orifice of the bile duct. So what I am going to use is the tip of the guide wire to engage into the orifice, and as I engage, I bring my up wheel upward to bring the scope closer to the ampulla, and as I am doing that, I push the sphincterotome out and my assistant bends the sphincterotome, and I elevate a little bit and pull the scope back and see whether we can engage the sphincterotome into the orifice. Here you can see I am engaged into the bile duct orifice. This technique is called kissing the papilla technique, because you go very close to the papilla in order to achieve cannulation. As you can notice over here, I go very close and bend. And simultaneously I turn and I try and push it in. I will ask my assistant to just attempt gentle maneuvering with the guide wire, because at this juncture sometimes the guide wire might just slip into the bile duct. No, but it has slipped out. And bend. As you saw, it was not possible to cannulate using the guide wire technique or the sphincterotomy technique. So we will proceed with needle knife sphincterotomy or accessotomy, a pre-cut papillotomy as we call it. We use the needle knife from Boston Scientific, the micro knife, to perform the sphincterotomy, because it gives a very precise cut and the cut can be controlled very well. So the needle knife, the micro knife can also be preloaded with a guide wire. We will preload it with a guide wire, so that as soon as we can get into the bile duct, we can proceed with the same instrument and perform the ERCP. To perform a pre-cut sphincterotomy, it is important to know the anatomy of the papilla. As we know, cannulation of the bile duct is performed in the 11 o'clock direction. However, for the pre-cut, it is important that we remain between 11 and 12 o'clock and closer to 12 o'clock on the most bulging portion of the bile duct, of the papilla, because this is where the intramural bile duct is going to be. And what we try and achieve in a pre-cut is we try and remove this intervening portion of the intramural bile duct and reach right up over here where we can enter the bile duct and then perform the ERCP. So you can watch my hands now. I control the endoscope using the elevator a little bit, but I fix the position of the sphincterotome using the elevator, and then I use this torque movement using the shaft of the endoscope and the handle to get lateral movement. The needle is engaged at the tip of the papilla, and using an endocut current, a superficial cut is performed. The cut is always performed in a layer by layer manner, so that we do not perform too deep a cut which can cause bleeding. Once we have got some cut and some depth, it is important to retract the needle and perform this maneuver, which I call as the milking of the papilla. It is important, just push the cut edges away in order to evert the papilla. It exposes the inside of the papilla much better and helps in the further incision if required. Then there are certain maneuvers and certain steps that one needs to follow when we are performing an ERCP. The first step is that the duodenoscope should be in a short loop position as far as possible, because this is the easiest position to achieve bile duct cannulation. all the wheels, the right, left and the up down wheels should be free and should be in a neutral position as far as possible, and the endoscope in this position will face the medial wall of the duodenum with the ampulla being face on. It is important to see the entire ampulla, not only the orifice, but also part of the intramural bile duct bulging portion of the ampulla, which encases the intramural portion of the bile duct. Once this is visualized, the sphincterotome is advanced out of the endoscope, and using the elevator, it is elevated to about half the sphincterotome usually exits at around 4 o'clock position on the screen, and it should be directed towards the 11 o'clock direction, in which this is the direction in which the bile duct lies, and therefore it is important that the endoscope, the sphincterotome and the bile duct come in one straight line. The maneuvers that are required in order to achieve this alignment are movement of the elevator, the up down wheel, the right left wheel, pulling and pushing of the endoscope inside the duodenum or out of the duodenum slightly, and torquing movements either in the clockwise or in the anti-clockwise direction. A combination of these 5 techniques is required, and it is important not to just force the sphincterotome into the papilla, but to achieve a good alignment before we advance the sphincterotome into the papilla. The sphincterotome is advanced gently into the papillary orifice, and once it is engaged, the guide wire is gently manipulated using gentle jiggling maneuvers in order to find its way into the bile duct. The endoscopist can change the movement, change the position of the sphincterotome and the direction by the maneuvers that I have described before, and the assistant can bow the sphincterotome in order to achieve the correct alignment. While performing ERCP, we must remember that every ampulla is different, and therefore the approach to cannulation for every ampulla must also be necessarily different. The ampulla may be small or it may be large, it may be flat or it may be bulging, it may be inside a diverticulum or there may not be any diverticulum, it may be rotated either in the clockwise or the anti-clockwise direction, or it may be facing either medially or laterally. Many variations have been noted. Sometimes the ampulla may be deep-seated at the junction of the second and third part, or sometimes it may be proximally situated at the junction of the first and second part. Every ampulla deserves a special mention and a special treatment, without which the endoscopist will not be able to achieve cannulation in every ERCP.